Good afternoon, everybody. I'm Pat Stone. I'm the Centennial Professor of Health Policy and the Director of our Center for Health Policy here at the school. I also direct our NIH-funded Center for Improving Palliative Care for Adults with Multiple Chronic Conditions. I'm really excited to welcome everybody to our policy dialogue for the future of nursing home quality. This is a panel discussion based on the National Academies of Science and Engineering Medicine's recently released report, The Quality of Care in Nursing Home, which examines how our nation delivers, regulates, finances, and measures quality of nursing home care, including the longstanding challenges which were really brought to light in the pandemic. Today, we couldn't be more pleased to be joined by our distinguished panel of experts that were all part of the committee and our moderator, Robert Weech-Maldonado. Dr. Weech-Maldonado, sorry, Rob. It's easy for me to say. Is a professor at the L.R. Jordan Endowed Chair in the Department of Health Services Administration at the University of Alabama at Birmingham. He's also a senior scientist at UAB's Center for Comprehensive Healthy Aging and deputy editor of Medical Care. He's also an organizational theorist with expertise in long-term care, patient experiences with care, health disparities, and cultural competency. Today, he'll introduce our panel members and moderate our discussion. Rob.
Thank you, Pat. I'm very excited to be here with all of you. Today, we will be hearing short presentations from our panelists, and then we will have about 20 minutes for discussion. Now, I would like to remind all of you to please use the chat feature at the bottom of your screen to ask questions to our speakers. We will address these questions at the end of our program during the Q&A session. Now I want to introduce our exceptional panel. As a note, each panelist's full bio will be in the chat so you can learn more about their incredible work and accomplishments. First, Dr. Colleen Galambos is a professor in Helen Bader Endowed Chair in Applied Gerontology at the University of Wisconsin-Milwaukee, and adjunct professor with the Medical College of Wisconsin. Dr. Galambos' active research includes care transitions, advanced care planning, end-of-life decision-making, aging in place, health and long-term care systems, quality improvement, gerontology, older adults and behavioral health, practice approaches and work with older adults, family caregiving, and competency-based gerontological education. Dr. Jasmine Travers is an assistant professor of nursing at NYU Rory Myers College of Nursing. Dr. Travers' work focuses on designing and conducting research to improve health outcomes and reduce health disparities in vulnerable older adult populations using both quantitative and qualitative approaches. Dr. David Gabrowski is a professor of healthcare policy in the Department of Healthcare Policy at Harvard Medical School. Dr. Gabrowski's research examines the economics of aging with a particular interest in the areas of long-term care and post-acute care. Dr. Marilyn Rance is the Curator's Professor Emerita of Nursing at the University of Missouri Sinclair School of Nursing. Dr. Rance's work focuses on measuring effectiveness of nurse care coordination, exploring new delivery models of care for older adults, and technology development to enhance aging in place of community dwelling elders. Dr. Rance is an international expert in quality measurement in nursing homes. Dr. Greg Alexander is the Helen Young Alumni Association professor at Columbia Nursing. Dr. Alexander has a broad background in human factors, informatics, gerontology, patient safety, and quality improvement. I am now going to hand it off to Dr. Betty Farrell, who will give an overview of the core recommendations from the report. Dr. Farrell is the Director of Nursing Research and Education and a professor at the City of Hope Medical Center in Duarte, California. She has been in nursing for more than 44 years and has focused her clinical expertise and research in pain management, quality of life, and palliative care. Dr. Farrell was selected to the National Academy of Medicine in 2019, where she continues to serve as a key member of the leadership team for the report. So without further ado, Betty.
Thank you. And thanks to everyone for being with us today. I'm Betty Farrell, and I'm the chair of the Committee on the Quality of Care in Nursing Homes, the author of this study. And what a great sense of timing it was that our report was just released last week and that we have this opportunity to share it with you today. On behalf of the committee and the National Academies, I want to express our gratitude to our sponsors who supported this tremendously important work. We, who are the panelists today, are here representing the larger committee. The full 17-member volunteer committee brought their expertise from a wide range of disciplines and backgrounds. Today, we want to give you a brief presentation of the report and our final recommendations, and then we will follow that with time for discussion and to answer questions. I would like to really begin this panel by noting that nursing homes play such an important role in our nation's long-term care continuum. Nursing homes, as we all know, serve as a place where people get the needed support and health care. But as we would remind ourselves very often as we worked over the last 18 months on this report, the nursing home is also the place they call home. And nursing homes will continue to be needed in our society, even amidst other options for long-term care in the community. The 1986 Institute of Medicine report, Improving the Quality of Care in Nursing Homes, described many concerns at that time. And Over87 subsequently established more stringent standards and regulations. While there have been, of course, many improvements over these last 35 years, the enormous toll of the COVID-19 pandemic on nursing home residents, their families, and very much also on the staff brought renewed interest and this heightened awareness to the long-standing problems that continue to plague the nation's nursing homes. As part of our process, our committee held open meetings, public forums, where we heard from a variety of family members, consumers, interested people to share their perspective. One family caregiver of a resident in a nursing home wrote to this committee saying, quote, "The pandemic has lifted the veil on what has been an invisible social ill for decades." I'd like to now review the charge that was given to our committee when we began our work. In brief, the committee's statement of task was to examine how our nation delivers, regulates, finances, and measures the quality of nursing home care. Second, the committee was asked to develop a set of findings and recommendations to delineate a framework and general principles for improving the quality of care in today's nursing homes. And finally, while the COVID pandemic was not the main focus of the study, we were asked to pay attention to the challenges that have arisen in light of the pandemic. So one of the ways I try to summarize this is to say the issues that we are talking about today existed long before there was a COVID pandemic. And very importantly, all of the issues we will talk about today will continue to exist well beyond the pandemic unless our report is put into action, unless we can see real change in the United States delivery of nursing home care. Over the last year and a half, our committee had 5 committee meetings with many additional smaller group subcommittee meetings and 6 public information gathering sessions. We also collected narratives from residents, families, and staff. We performed extensive literature review to come to the evidence at hand on all of the issues we were addressing. And we also had 16 external reviewers who reviewed our final report. Our committee arrived at 7 overarching conclusions, which I think are very, very important. These 7 conclusions really represent the committee's beliefs after all of this work. The first overarching conclusion is the way in which the United States finances, delivers, and regulates care in nursing home settings is ineffective, inefficient, fragmented, and unsustainable. Another way to say this is it is broken. Second, immediate action to initiate fundamental change is necessary. Even prior to the pandemic, nursing home care was neither consistently comprehensive nor of high quality, and regulations in place for 35 years have not been fully enforced. Third, all stakeholders need to make a clear shared commitment to the care of nursing home residents. Fully realizing our committee's vision will depend upon the collaboration of multiple stakeholders. Fourth, extreme care needs to be taken to ensure that quality improvement initiatives do not exacerbate disparities in resource allocation, quality of care, or resident outcomes. And I will just add that our committee gave a lot of attention in every meeting that we had about issues of diversity and equity. And you'll hear more of that as my co-panelists talk about our recommendations. Fifth, high quality research is needed to advance the quality of care in nursing homes. In many areas, there's limited evidence to determine the best approach to care. Sixth, the nursing home sector has suffered for many decades from both underinvestment in ensuring the quality of care and a lack of accountability of how resources have been used. And finally, all relevant federal agencies need to be granted the full authority and resources from the US Congress to implement the recommendations of this report. Our committee already had the opportunity to hold 3 congressional briefings, and we're very eager ourselves and all of you who are also part of our community. We want a lot of interaction with policymakers at all levels to help implement our recommendations. Also, as a framework for this study, our committee created an original conceptual framework of high quality care, which is fully described in the report. What I want to point out from this model is that, as you can see, we recognize there are a lot of influencing factors or inputs. Family caregivers, consumer expectations, national and state policies, oversight, ownership, operators, many, many factors, the workforce, influence what really happens in the daily care of the resident in a nursing home. But the most important thing we want to emphasize in our model is at the center of this is a real person, a resident of a nursing home who is often very frail, very, very vulnerable, often without strong advocates or family supports, who depend on us to deliver high quality care. So this model really is here to depict that we want the residents of nursing homes. Our vision was that they would receive care in a safe environment that honors their values and preferences, addresses the goals of care, promotes equity, and assesses the benefits and risks of care and treatments. That's not too much to ask for a resident in a nursing home. Things like safety, that their values are heard. This is really a very patient-centered report. Improving the quality of care in nursing homes is not only possible, but it represents a critical societal and public health imperative. Through our recommendations, which focus on diverse areas for improvement, they share a common underlying premise, and that is that the challenges that face nursing homes are complex, they're multifaceted, and they require immediate attention on multiple fronts by many stakeholders. And finally, our committee emphasizes the vital importance of attention to health equity, which you will see woven throughout the recommendations. I would like to now turn to my colleague, Colleen, who will begin our very brief overview to the committee's extensive recommendation that fall into 7 critical goals. So Colleen.
Good afternoon. I'm Colleen Galambos. I'm a committee member, and I am delighted to be here to present Goal 1 to you. The committee's first goal is to deliver comprehensive, person-centered, equitable care that ensures residents' health, quality of life, and safety, promotes autonomy, and manages risk. While person-centered care is foundational to the basic requirements specified in existing federal regulations, such care is not yet a reality for many nursing home residents. A focus on care delivery that respects the resident's voice and diversity, care that is equitable and strives for the best and most attainable quality of life for residents and their significant others, and care that truly balances resident wishes and autonomy while assuring safety is the standard for nursing homes, government, and the broader community to work together to achieve. This standard requires the development of stronger connections between nursing homes, their communities, and government support. When we look at the resident, family, and staff perspectives, we see a number of comments that speak to the quality of care. One person remarked, while the nursing home company website and PR touted their commitment to person-centered care and treating residents like their own family, the facility was never able to provide even the most basic routine services uniformly and consistently. And another person remarks, there is no quality of care or quality of life. And worse, person-centered care is next to impossible. Aides and nurses do not want to be short or quick, but residents are just a box on the checklist to be done. And these comments were provided to us in public comments that residents, family, and staff were invited to participate in. These comments speak to critical gaps in the quality of care that exist in areas ranging from the development of a comprehensive care plan for each resident, including who is a part of developing the comprehensive care plan, such as CNAs, qualified nurses, and social workers, families, and the residents themselves, and what is included in the comprehensive care plan. This care plan should address behavioral health, psychosocial care, oral health, and end-of-life care, in addition to medical care needs. Additionally, significant disparities exist in the quality of care received across nursing homes. The committee recommends a number of actions to address these shortcomings. First, the committee calls for immediate and consistent compliance with existing regulations for care planning. Putting this intent into action requires recommendations for RNs to provide this oversight and for all members of the interdisciplinary team to contribute to the care plan. Care plans should include resident preferences, and preferences should be obtained regularly and systematically. The care plan should focus on medical care needs and emphasize psychosocial, cultural, spiritual, and behavioral care, as well as physical care. Second, evidence on best practices for the provision of a broad array of services is scarce. The committee recommends research and demonstration projects on effective and innovative models of care. We need to test optimal models where residents are able to thrive, disparities are reduced, staffing is ideal, technology is used to enhance care, and leadership is strengthened and supported. Third, even before COVID-19, nursing homes were largely unprepared to respond to emergencies and natural disasters. The committee provides recommendations to strengthen nursing home preparedness, to protect residents and staff, and to emphasize their inclusion and preparation in any public health response. This includes the development of formal relationships with public health emergency management departments and ready access to supplies such as PPE. Finally, given the vital role of the physical environment to quality of life, the committee has several recommendations to create smaller, more home-like settings of care that support more opportunities for social connection and engagement, strong infection control practices, and connection to clinical staff. The committee recommends features such as open kitchens, therapeutic outdoor areas in all nursing homes, spaces for socialization, workspaces for clinical staff, private bedrooms and bathrooms, and new environmental designs that allow flexibility to address a range of resident care issues. And with that, I will turn the program over to Dr. Jasmine Travis, who will talk about workforce.
Thank you so much, Dr. Galambos. Okay, so the committee's second goal is to ensure a well-prepared, empowered, and appropriately compensated workforce. It has been a challenging 2 years for nursing home workers, to say the least, as they continue to contend with high turnover, extreme staffing shortages, and limited training, knowledge, and resources available to them. Next slide, please. Just to read some additional quotes. One individual reported to us, there are so many types of facilities I have been in, and no matter what, staffing is what makes or breaks it. Second individual, family member, the reality is that the staff is underpaid, overworked, undersupported, and insufficiently trained to care for residents. Just to add to this, workers in nursing homes, many who are nurses and nursing assistants, are often underappreciated, undercompensated, and underprepared for their roles in providing increasingly complex care. Decades of evidence support the need to enhance their training, salaries, and working conditions, yet little progress has been made to improve the quality of these jobs. The committee recommends increasing both the numbers and qualifications of virtually all types of nursing home workers. This may be concerning given the dire staffing situations for many nursing homes. However, robust evidence demonstrates the positive impact of enhanced staffing and training requirements on the quality of care. Enhanced requirements will further professionalize the nursing home workforce, which, when accompanied by improvements in the work environment, will contribute to the desirability of working in a nursing home. Next slide, please. First, successfully recruiting and retaining a high-quality workforce depends on more than adequate compensation. Rather, the committee calls for ensuring competitive wages and benefits, including health insurance, childcare, and sick pay for all nursing home workers. Next, the committee calls for the immediate implementation of higher staffing standards in nursing homes. For example, 3 previous studies of the Institute of Medicine recommended the 24-hour presence of a registered nurse, yet this has not been made a requirement. More concerning is the same federal staffing regulations have been in place for decades, even though the types of residents and the complexity of their needs have changed dramatically. The committee recommends research on minimal and optimal staffing standards for all direct care staff, such as nurses, therapists, and social workers, updating regulatory requirements based on this research, and strategies for acquiring additional expertise for advanced care needs. Given the role of certified nursing assistants, or CNAs, in providing the majority of hands-on care to residents, the committee provides recommendations for empowering CNAs, including career advancement, peer mentoring, free entry-level training and continuing education, role expansion, and new models of care. Education and training requirements such as competency-based training, culture change, administration, and financial management for a variety of staff are inadequate or non-existent. The committee recommends minimum education and competency requirements to be made standard nationally. Beyond these baseline requirements, the committee calls for annual continuing education, ongoing diversity, equity, and inclusion training for all staff, including leadership, and resources and training for family caregivers, and for family caregivers to be included as part of the caregiving team. This is important to truly transform the working conditions and environments that staff and residents are exposed to. A greater number of professionals need to be involved in nursing home care, such as nurse practitioners, physicians, and physician assistants, yet data are limited on these types of workers, including their numbers and the extent of their training and expertise. The committee recommends the collection and reporting of such data, including for contract and agency staff. Finally, more information is needed regarding systemic barriers and opportunities to improve recruitment, training, and advancement, as well as for job quality indicators such as turnover and job satisfaction. I'd like to now turn to my colleague, Dr. David Gabrowski, who will discuss the next two goals.
Great, thanks, Dr. Travers. In 25 years of working on nursing home policy, I've continually heard from residents, their families, and their caregivers that this current model is not working effectively for them. Nursing home care, as Dr. Farrell said earlier, in the US, it's broken, and this report, we believe, provides a roadmap forward for the US towards transforming the system. So our third goal is to increase the transparency and accountability of finances, operations, and ownership. Next slide, please. A key barrier to effective nursing home oversight has been a lack of transparency regarding nursing home finances, operations, and ownership. CMS makes some ownership information available, but these data are incomplete, often difficult to use, and do not allow for assessment of quality across facilities owned or operated by the same entity. Moreover, there is little transparency regarding the practice of some nursing homes to contract with related party organizations that are also owned by the same nursing home owner and provide services such as management, nursing, or therapy. Increased transparency and accountability are needed to more fully evaluate both how Medicare and Medicaid payments are spent and how ownership models and spending patterns impact the quality of care. The committee recommends collecting, auditing, and making detailed facility-level data on the finances, operations, and ownership of all nursing homes publicly available in real time in a readily usable database that allows for the assessment of quality by common owners or management companies. Next slide, please. The committee's fourth goal is to create a more rational and robust financing system. Next slide. The current approach to financing nursing home care is highly fragmented, and you can see that from the quote on the slide here. My mother had a private room because she paid out of pocket, spending the last $200,000 of my parents' lifetime savings before depleting her bank account. It's expensive. It's not well connected to other services. Next slide, please. The federal state Medicaid program plays a dominant role as a payer of long-stay nursing home care, but is constantly subject to state budget constraints. The federal Medicare program only covers short-stay post-acute care in nursing homes. Services such as hospice care are paid separately and not well integrated into standard nursing home care. Private insurance coverage for long-term care is limited, and relatively few people can afford to pay out of pocket for an extended nursing home stay. In an effort to create a more rational approach to financing nursing home care that would address these significant shortcomings, the report includes a recommendation about moving toward a federal long-term care benefit by studying how to design such a benefit and then implementing state demonstration programs to test the model prior to national implementation. As Dr. Farrell said earlier, our current system is ineffective, inefficient, fragmented, and unsustainable. Once again, if we want to transform this system, we can't nibble around the edges. We really need to completely change how we finance and pay for services. Next slide, please. Oh, go back, sorry. The fragmented financing system leads nursing homes to rely on higher payments for Medicare services to cross-subsidize lower Medicaid payments, an inefficient and unsustainable arrangement. In general, states are required by law to provide assurances and sometimes evidence that Medicaid payments are adequate to provide access to high quality care. Nursing home payment rates, however, are not subject to this requirement. To ensure adequate investment in caring for long-stay nursing home residents, our committee recommends the use of detailed and accurate financial information to ensure payments are adequate to cover comprehensive nursing home care. The committee also recommends designation of a specific share of Medicare and Medicaid payments for direct care services, as opposed to spending on non-care items such as lease payments. For short-stay post-acute nursing home care, the committee calls for extending current bundled payment arrangements to all conditions in an effort to advance value-based payment based on quality, not quantity of services. Additionally, the committee recommends demonstration projects to explore the use of alternative payment models for long-term nursing home care, separate from the bundled payment initiatives for short-stay post-acute care. I now hand off to my colleague, Dr. Marilyn Rands. Marilyn?
Thank you, David. For the next two goals, I must say the topics of quality assurance and quality measurement and quality improvement have been central to my life's work in nursing. Now, over 50 years as a registered nurse. And most of that time devoted to caring for older people as a director of nursing, as an administrator in a large county nursing home for many years, and then a nurse researcher. Our committee was diligent in locating, synthesizing, and applying the evidence that we could locate for all of our recommendations. So I want to reassure you that this is evidence-based, and our commitment is here that improving the quality of care is our passion and our total commitment. It can be done, and it will be done by implementing the recommendations in this report. And as we've said, we consider all of the recommendations. The committee's fifth goal is to design a more effective and responsive system of quality assurance. Although federal oversight standards and processes are uniform across states, considerable variation exists in the implementation of routine inspections, in the imposition of sanctions, and in the investigation of complaints. The survey process often fails to identify serious care problems, to fully correct and prevent the reoccurrence of problems, and to investigate complaints in a timely manner. Next slide. These are quotes of the residents' and families' perspective, pointing to those quality of care and complaint problems. Then the next slide. Currently, CMS does not provide sufficient oversight or transparency in the survey process. The committee provides recommendations to ensure state survey agencies have adequate resources and for oversight of state survey performance. Despite the prominent role of nursing home oversight and regulation, the evidence base for its effectiveness in ensuring a minimum standard of quality is relatively modest. The regulatory model needs significant improvement. However, there's little consensus or evidence to suggest which approaches would ultimately lead to improvements in quality of care. The committee recommends developing and evaluating strategies to improve quality assurance activities. Further study here is needed. The committee provides several other recommendations related to quality assurance, including increased funding for the long-term care ombudsman program and its collaboration with other state-based entities, denying licensure in imposing enforcement actions on owners with a pattern of poor quality care across facilities, and the elimination of certificate of need regulations and construction moratorium. Next slide. To improve the quality of care, the committee's sixth goal is to expand and enhance quality measurement and continuous quality improvement. It is essential that we solicit directly from the resident and family. Next slide. Their perspective and experiences receiving care in the nursing home. The committee recommends that the CHAPS measures be systematically collected and reported. Similarly, experience measures of care in other healthcare settings have been collected and reported for years. It's time for the experience of nursing home residents to also be reported. Their voice is necessary. Next slide. The CMS in addition to the CHAPS measures, the CMS website Care Compare provides data on the quality of nursing homes. However, many key indicators of high quality care are missing, and several improvements are needed to enhance the quality of the reported data. The committee recommends adding several measures to Care Compare, including the CHAPS measures of resident and family experience. The committee also recommends facilitating the ability to examine performance across facilities, including across state lines, with common ownership or management, improving the validity and improving differentiation in the 5-star composite rating. Additionally, more work is needed to develop valid measures for key domains of quality, including palliative and end-of-life care, satisfaction, staff satisfaction, psychosocial and behavioral health, and various structural measures. The quality of nursing home care is particularly concerning for several high-risk populations who experience significant disparities in care. However, the lack of robust data makes it difficult to document the true extent and impact of disparities in care. The committee recommends the development of an overall health equity strategy for nursing homes, which includes a minimum data set, a national report card, culturally tailored interventions and policies, and strategies to identify and address disparities. The tragic disproportionate results for people of color dying in nursing homes during the COVID pandemic cannot be allowed to ever reoccur. Finally, many facilities lack the adequate expertise and resources for effective quality improvement. The committee recommends the development of technical assistance programs at the state or even local level by individuals who are most familiar with the nursing home specific community and challenges, who have specific expertise in nursing home quality, and who have a consistent and ongoing focus on nursing homes. I'll hand off to my colleague, Greg Alexander, an expert in health information technology, for our next and final goal.
Thank you, Dr. Rance. Closely linked to quality improvement and improved quality care is the committee's 7th and final goal to adopt health information technology in all nursing homes. Next slide, please. HIT can contribute to personalizing the care interventions of resident needs and desires in an efficient and accurate way. For example, nurses can specify individualized plans of direct care so that nursing assistants can assure approaches to each person, that those approaches are what the patient wants and what they need. Health information technology also increases efficiency in care delivery, enhances care coordination, can improve staff productivity, and promotes patient safety while also helping to identify and reduce health disparities. Residents often have complex conditions that require care coordination across multiple settings, further underscoring the need for nursing homes to have electronic health records, or EHRs, that communicate with other systems to ensure smooth, accurate transfer of clinical information between settings and safe care transitions. While previous federal programs provided incentives to certain healthcare professionals and hospitals to support EHR adoption, nursing homes were not eligible for such incentives. The committee recommends identifying pathways to provide financial incentives to nursing homes for adoption of certified EHRs. During the COVID-19 pandemic, those nursing homes using HIT applications had access to critical means of communication when lockdowns led to limited access to in-person clinical visits and resident isolation from friends and family members. Can you imagine how much better the experiences of isolation, loneliness, and dying with no family members to comfort you in your last days or hours could have been if all nursing homes had health information technology like other care settings? How much better the clinical care could be if all nursing home leaders and direct care staff have the information that can be readily compiled and easily reported for important health events like falls, or urinary tract infections, or upper respiratory tract infections, or skin breakdown, or any other myriad of chronic conditions. Armed with real-time information about these health events, nursing home leaders can work with direct care staff to isolate underlying environmental or care conditions that, if remedied rapidly, resolve the underlying causes and result in better health outcomes and quality of life for residents. That is real-time quality improvement facilitated by health information technology. The committee also recommends the development and reporting of baseline measures of HIT adoption and interoperability, that is the ability to communicate with other EHRs. Moreover, it is vital to understand the various barriers and facilitators to HIT use in nursing homes in order to improve the efficiency, effectiveness of, and satisfaction with health information technology for staff, as well as for residents and family. As nursing homes adopt health information technology, training of nursing home leadership and staff in core HIT competencies is absolutely essential. Finally, ongoing evaluation studies are needed to assess the impact of HIT on resident outcomes, to examine innovative uses of HIT, and to understand disparities in HIT adoption and use across nursing homes. So I have some final thoughts on our next slide. In closing, we obviously only have given a very broad overview of this report, but I would like to emphasize that there's an incredible amount of detail in the 600 pages of the report if you haven't seen it yet. I would encourage you to pay particular attention to Chapter 10, which provides a deeper dive into the context and specifics of each recommendation that we have only briefly touched on today. The time to act is now. The need to reform how care is financed, delivered, and regulated in nursing home settings is urgent and undeniable. Failure to act will guarantee the continuation of many shortcomings that prevent the delivery of high quality care in all nursing homes and pose a threat to residents' health and safety. The COVID-19 pandemic provided powerful evidence of the deleterious impact of inaction and inattention to long-standing quality problems on residents, families, and staff that have occurred for years. At the same time, however, the pandemic serves as an opportunity for change, to drive critically important and urgently needed innovations in this space. Implementing the committee's integrated set of recommendations will move the nation closer to making high quality, person-centered, and equitable care a reality for all nursing home residents. It has been 35 years since the passage of the OBRA 87 and landmark nursing home reform measures. It is of the utmost importance that all nursing home partners work together to ensure that residents, their families, and staff will no longer have to wait for needed improvements to the quality of care in nursing homes. Again, the time to act is now. We thank you for your attention while we've covered these recommendations, and I'd like to open things up for discussion and invite your questions. Rob will be moderating the rest of the panel, so thank you very much.
Yes, thank you, Greg. Wonderful. Thank you so much for those great presentations. And I appreciate also the comments that the audience has been making, very valuable comments. We're going to be picking a few of them, particularly those relating to questions. And the first one we have is from Deb Purcell, and I'm going to have Colleen and Marilyn address this. She's asking specifically about the role of infection preventionists, and in particularly, in terms of their role as being part or an important part of a high quality workforce.
So I'll start by saying, first of all, what we were trying to do is increase the standards, because as it stands now, it's often people who don't have the qualifications, training, or expertise who are put in charge of infection control. So by designating an individual in the facility, and again, coupling that with training will help ensure that infection control is covered much more adequately than it is now. The committee felt that it was important to select someone who was in the facility on a day-to-day basis, who understood what happens 24/7 in a nursing facility, to be able to think about some of those daily procedures where infection control is so important. it doesn't preclude nursing homes from consulting with an infection control prevention specialist. We do have recommendations further on in the report that talk about in terms of complex care and other situations that nursing homes should capitalize on expertise of consultants. So in that way, that could be covered by handling infection control by bringing in a consultant. And also, it doesn't mean that somebody couldn't be hired with higher qualifications than an RM. Marilyn, do you have anything to add to that?
No, I think you've covered it quite well. We really wanted to make sure that we had, that we looked at realistically the operations, day-to-day operations, and that we had a well-prepared person who would be an infection preventionist to add to and be able to integrate changes that needed to take place within the nursing home. So we were targeting operations.
And I'm reading the chat, and there is a comment that there is a specific role for IPs. I don't think we. I think we agree with you, and I think that there's a way to wrap that in, but also to use those day-to-day people who can really handle the day-to-day operations and pinpoint where infection control is an issue or a problem.
And if a nurse is the person who's designated, that person needs to be trained as an infection preventionist.
And so
Jasmine,
perhaps
you have something more?
And perhaps maybe one of the other responsibilities of the IP specialist is to really provide training that is accessible so that RNs and others can receive that training.
All right, thank you, Colleen and Marilyn. Another comment, and I'm going to direct this one to Jasmine, was related to the role of non-direct care workers in preparing food and keeping the facilities clean. The comment was from Jimmy Kissinger that they were also equally important in this equation. So I was wondering, Jasmine, if you could comment on that.
Sure, thanks, Rob. I would highlight and emphasize that our report reflects the importance of all nursing home workers working together as a unit, and the importance for the knowledge that each worker has about the resident, and then understanding what the resident's preferences are to inform what the worker is actually doing. So for example, the environmental service worker, there was a quote within the report that acknowledged not the environmental service worker, the housekeeper, acknowledged the importance for the housekeeper, maybe understanding that the resident likes their Bible right at the bedside. So that being a need. Or for the person who prepares food, their ability to prepare the food in a way that the resident appreciates. And then just in addition to that, when it comes to our recommendations, oftentimes while we provided specific examples of particular workers, our recommendations, a lot of them are for all workers. So when we talk about increasing the pay and the decrease of the lower pay that we see among workers in nursing homes, we're talking about all workers within these settings. So we are right there with you all when thinking about the importance of both non-direct care workers and direct care workers. And our recommendations and the information in the report reflects that.
Thank you, Jasmine. I think this next comment may be good for David. Kim Bergen-Jackson, she talked about that she would like to see a regulatory model focus on implementing a more collaborative model, providing recommendations and evidence-based guidance to chronic poor performers while encouraging high performers. She believes the gotcha mentality doesn't work and allows longtime poor performers to pay a fine and continue on. I was wondering if you had any comments on that.
Yeah, this is a thorny one in an area where there's been a ton of back and forth. I'm looking at Pat Stone as a mainstream this. Pat and I served together on the CMS Coronavirus Commission, separate from this committee, and that this issue came up there of what's the right balance between sort of a collaborative role for regulators versus more of a punitive one. And I think it really is an issue of balance. I think if you talk to advocates, they really believe that you need that enforcement and oversight. Yet if you talk to providers, individuals who are working in the facilities, they really believe that they need to learn how to improve care. It's not enough. You can find me, but if you find me, that doesn't mean I know what to do next time. And so we believe as a committee, the importance of the QIOs, quality assurance activities. There's a lot that can be invested into sort of in the long term, kind of improve that education. It doesn't have to be one or the other, but this is a kind of a thorny issue, and one that I think is going to continue to be sort of debated back and forth across sort of advocates and providers. But I hope we're able to find a balance and move forward. Thanks.
All right, thank you, David. This next comment from Lorraine Frazier. Perhaps Marilyn or Colleen could, comment a little bit about patients with developmental disabilities. She says, don't forget about them that are now living longer. So I wonder if you had any follow-up on that.
Do you want me to start, Marilyn?
Sure.
Okay, so there is the PASSR screening process is supposed to screen inappropriate admissions to nursing homes, including persons with developmental disabilities. Now we know, even despite this PASSR screening process, that people with developmental disabilities are being admitted into nursing homes. And sometimes for appropriate reasons, they may have other medical needs or other comorbidities that land them in the nursing home. But our recommendations really do focus on beefing up behavioral health, making use of consultants and other services, hiring qualified staff who can handle behavioral health care issues as they emerge in the nursing home setting. So this definitely emerged as a huge deficit in terms of how nursing homes are handling behavioral health. And there are many people on the screen who've actually done the research and written on this. We do see it as a deficit. We do know that more expertise is needed to handle behavioral health in the nursing home setting. And we also are asking for additional research to be conducted so that we can develop better models of providing behavioral health care in nursing homes.
I think you've covered that quite well, Colleen. We did wrestle a lot as a committee and discuss this issue of developmental disabilities too, because there are residents in nursing homes and have been since for many, many years. And since I was a nursing home administrator, there were lots of people with developmental disabilities. Now, most of them are living in the community, but as they age, it is a population that will be coming and that is coming into nursing homes. So that needs to be taken into account. And I think our recommendations have covered that quite well, although not specifically that specific population. But as Colleen said, with the people that we want to encourage to come into the homes to consult and to be there and to make sure that the staff is prepared for the population that they have.
All right, thank you very much. That was very helpful. I have now kind of a broader comment from Adina Borgad, which I think it's very important. And I'm going to have Betty get started on that and others can chime in. But she was basically saying reforms for nursing homes have been proposed since the 80s and the 90s and as recently 2016. What do the panelists think is different now in terms of implementations of the NASM recommendations?
Thank you for the question. Our committee, at many places in our report, you'll see that we acknowledge that since the previous report in the 1980s and with the implementation of OBRA, many of the regulations that are needed are already there. They're on the books. They just have not been reinforced. And so throughout our report, we really call for immediate action to provide the resources so that at a state level, at a federal level, that we can see existing regulations really reinforced, that there are really penalties for not meeting the quality recommendations. And we also see that there have been some many advances since the report in the 1980s, but that I think now everyone has been made so aware because of COVID of just the enormity of the deficiencies. And so we're really encouraged. We think that there is, great momentum, that across disciplines, there's a great commitment to improving care. And so, but it will take resources, it will take commitment, across many stakeholders. And we've tried to really acknowledge that in our report.
And related to that, Betty, many of the recommendations are at the health policy level, right? So, such as reforming financing regulations and so forth. So how do you think the professional community can advocate for these changes at a health policy level?
Sure. So I think some of you may, be aware that just about 3 weeks ago, I think, so just shortly before our report was released, the Biden administration, through the State of the Union, announced the administration's commitment to major change in nursing homes. And as I mentioned, when our report was being released last week, the day before our report release, we held 3 congressional briefings. So, our sense is that there are many committees, there are many groups within policymaking bodies, within Congress, that certainly now have been made aware of the problem. So one thing that every concerned professional can do is to be in touch with policymakers, with your senators and representatives, with all of your contacts, to really encourage them to read the report, to act on the report, to support the efforts that we call for, such as funding for state agencies. And there are very specific recommendations. So in the report, we have an appendix where we've even prioritized in terms of which things, all of our recommendations we believe in, all of them need to be implemented. But we've even tried to give a timeline, what things can happen now, what things can happen in the next year, what things will take some additional, study and formulation. But every one of us needs to be really pushing for policymakers. We've written this 600-page report. We've given detailed recommendations. There's a blueprint right here. And so now it's time for our government agencies to act, to give the resources, and to get on with better care.
Betty, thank you so much. Thank you all panelists and Rob. I can't say this has been so, and thank you for all the people that have been here listening and the active chat going on and your concerns. I really appreciate it. I do hope you take Betty's advice and try to make this report go into action. I also, of course, want to thank Sharon Sobel and Janice Grady from Alumni Relations, Judith Kelson and Bridget Morris-Carson from their Center for Health Policy. They've done all our coordination, and also this has been supported by the Center for Health Policy and the NIH SIPC Center. So I want to thank you all for being here, and thank everybody. This has been great. One thing, Betty, somebody asked if this, we'll have the recording available. Somebody asked about the slides. Are the slides available on?
The complete report is already available online, free, can be accessed free. A published version will come out later. And the slides will also be available. I know there was an early version of slides, and then I think a more complete version will be available later. But anyone can go to the it's just nationalacademies.org/ nursing dash homes, and that will take you directly to all the resources that will be available there on the report.
Thank you. Again, thanks everybody so much. This was really a wonderful discussion, and thank you for your work on the report. Much appreciated.
Sure. Thanks,
Wonderful.
everyone.
Thank you.
Thank you.